Hi, it's Dr. Fox. This is part 2 of the borderline personality disorder and psychosis video, and I hope you watched the first part. It really explains all of those symptoms so that as we go forward, you have a better understanding of the issues that we're going to talk about and the concerns that can occur in those with BPD. Now, in this video, we will examine BPD and psychotic symptoms, the confusion related to the comorbidity and what I'm calling complex BPD, prevalence, and how they relate to those dealing with and managing BPD. Now, if you haven't watched part 1, please do so, which will provide a nice foundation of understanding of what we're going to discuss in this video. Otherwise, this video may be a little confusing, a little overwhelming, and nobody wants that. So please like, share, and subscribe. That would be great, and let's get into it. One of the confusing aspects of BPD and psychosis relates to the classification manuals. Now, that includes the DSM-5 and the International Classification of Disease and Related Health Problems, the ICD-10. Now, they each specify that the presence of a major psychotic disorder precludes BPD as a diagnosis. However, if you remember all the way back to the first video that I mentioned that 24% of those with BPD experience severe psychotic symptoms and 75% had dissociative and paranoid ideation, which is a component or can be a component of psychosis. So that's where it's confusing, right? Well, there's additional data that hallucinations are experienced by 26 to 54%. This is all based on research. And 17 to 29% experience delusions and BPD. So you see, right, where the confusion is. So sometimes it's in the manuals. That's why it's so important to make sure the person you're working with understands the complexity of BPD. That's why I'm really trying to stress this fact of a pure BPD, right, and a complex BPD. And if you haven't seen that video, you may want to go and check that out to have a better understanding that most folks have complex BPD, not pure BPD. Okay, but that's, of course, for the other video. Now let's talk about severity. So when we talk about severity, so psychotic symptoms or features among individuals with BPD are typically defined as mild and transient and hallucinations-like in nature. Now I talked about this at the end of the first video, which is that most folks may qualify for a brief psychotic disorder, but many more are likely to have what's called a psychotic break, which is this massive increase in stress for whatever reason, right? Way beyond what you can typically tolerate. And then you start to have delusions, hallucinations, other types of factors. And then you go to the emergency room, right? The individual seeing you there doesn't really have time or doesn't collect a good history. And then what happens? Boom, they hit you with schizophrenia. And that changes everything, because as you go forward, all of your medical and mental health providers are going to see the schizophrenia, and that is what they're going to beam in on. Whereas if you have this underlying personality disorder, BPD, because that's what we're talking about, things are much more complicated. So what happens is they may increase antipsychotics to a level where you're kind of zombied out. And I've had clients who have had that experience where they've been sort of zombied, right? That's what they call it, because they're on such a high dose of an antipsychotic that it's hard for them to think, it's hard for them to function. And they're like, well, I'm also, I have schizophrenia. It's like, okay, well, let's kind of work and tease it out. And we realize it's more BPD stuff than it is schizophrenia, because they don't have all the other criteria. They just had a psychotic break. So that time component, again, this is why that first video is so important, that you understand the time component, understand all of those symptoms, okay? But we're in video 2, so let's keep going in video 2. Okay. Now, there's a difference between the types of hallucinations and those with BPD. Now, these can include like benign types of hallucinations and hallucinations and pathological ones. These are called like neutral versus negative content. There's also high versus low control. And there's also, right, what's called low versus high frequency. Now, the hallucinations experienced by individuals falling to the more severe side, right, the more severe category, these tend to have a worse prognosis, as you can imagine. Now, what does that mean when we talk about hallucinations? I don't want to confuse you, okay? So let me go over. This is the part where it would increase the level of severity. Now, these are hallucinations that have negative content, they have low control, and they're higher frequency, so they occur more often. And you may be saying, well, aren't all hallucinations negative content? No, actually, just this past week, I was talking to a client, and this individual had experienced some pretty extreme abuse in their past, and following that abuse, they had started to have a visual hallucination, and along with the visual, there was auditory, and this was a comforting figure that would say, you're going to be okay, you're not going to be alone, I'll always be with you, things of that nature. So that's very different than something occurs, you have a hallucination of command hallucinations saying, you're worthless, they're going to get you, so on and so forth. It happens very often. You can't control it. I've worked with a lot of folks that do have these types of hallucinations, and they're able to distract themselves, distance themselves, and then there are some that can't, that don't. So that's part of that distinction. So we never want to just assume that all hallucinations are negative, that all hallucinations are these command hallucinations to hurt yourself and things like that. There is variability in there. Now, of course, we hear more about the negative, obviously, hurtful, threatening hallucinations because they're more hurtful, they're more threatening, and there's a greater degree of fear associated with it. But they're not all. Now, that doesn't mean that you're like, oh, well, that's a positive one. Well, that's great. Then we don't have to worry about that. That's not true, because we recognize, even with this individual, and this individual, I said, I'm doing something on psychosis. Do you mind if I talk about it? And this individual was like, no, I don't mind. So they were cool with it. But it's important, though, to recognize that I believe, and what we talked about, is that as we move forward and we start to resolve some of these traumatic issues, the trauma issues, that this hallucination may occur even less frequently, may not be as impactful, but also there's a component of this that's comforting for this person. And it's like, well, what we'll try to do is replace that comfort with something else that is there, right? Try to create a transitional object that can help. Should decrease the impact, presence, frequency of this hallucination while increasing this individual's sense of control. So this will be a therapy that will probably last a very long time. We had that discussion as well. In individuals, right, with BPD, psychotic symptoms tend to occur in reaction to stressful events, right? We know that. That's criteria number 9. Okay, now this may be consequences of childhood trauma, specifically high sensitivity to stress and symptoms of PTSD. So we know that PTSD is prevalent in those with BPD. Is actually between 58 and 79% of those diagnosed with BPD. And PTSD can include psychotic symptoms or could promote the appearance of having a psychotic episode, right, by intensifying stress. Now, a lot of people write me and they say, what about complex PTSD, and BPD? Now, I've done a video. I'll put that link here so you can check that out. I think I'll do another one that I'm focusing on now, which is more complex BPD as opposed to pure BPD. So I may do another video on complex PTSD and how that relates to complex BPD. Okay, so what do we do about it? What do we do if you're an individual who has BPD and you have these psychotic symptoms and psychosis? Well, research findings are all over the place. Okay, some showing benefit and some showing none. Okay, so there is benefit, there isn't benefit. What are we looking at? What can we do? I've listed a lot of citations for the data that I've used for these videos, as well as to educate my clients over the years. And you can check those out. But when we look at everything together, okay, The results show some support for the use of what are atypical and antipsychotics. That's your Risperdal, your Zyprexa, your Seroquel. In BPD individuals with BPD are often related to stress and acute emotional crises. It has been suggested that psychotherapy should focus on managing crisis on the treatment of psychotic symptoms in BPD. Okay. So that is important as well, about managing this crisis. Now, I did a video on that. I'll put that link there, about using these coping strategies to try to manage that level of distress, to try to manage the occurrence of emotional turmoil and things of that nature. And I have several videos on that as well. You can check those out. And I think that just developing those adaptive strategies, I've seen a lot of my clients over the years really develop some good coping strategies, management strategies, and they have been able to get a hold of how they experience stress, about how they experience relationship turmoil, of how they experience their life, and having greater control over their life. And it is possible to do it. BPD is the most successfully treated personality disorder. So please don't forget that, and please take care of yourself. And I hope you enjoyed these two videos, and I'd love to hear your feedback. So thank you very much. I know it is a lot of content, and I wish you all the best, and thank you very much. Hope you found it useful. Thank you. Bye-bye.